Now I can also hear you. Wonderful. Okay, thank you very much. Yeah. Okay, so we are here with our live case, our venous, deep venous stenting case with Ms. Dr. Yvonne Bausbach from our center, and also Dr. Alt. He's also associated to our hospital, and he's actually the doctor who sent our patient here, and also anesthesiology is helping us here in our case here. Yeah, maybe Yvonne, you can introduce the case.
Yes. Hello. We have a 48-year-old female patient, and would like to show you the endovascular treatment of this May-Turner syndrome. It's a post-thrombotic syndrome. The next slide, please. Yeah. So the patient is suffering from venous insufficiency C5 with a non-healing venous ulceration on the left calf. She has had recurrent iliofemoral DVTs on the left, and the first one 20 years ago during her first pregnancy, then followed by a pulmonary embolism in 92, also diabetes mellitus type 2. Next, please. And this is the physical aspect of the patient. You can see the ulceration, also an incompetent saphenous magnum vein, and you can see the ultrasound that we performed. You have an open saphenofemoral junction, a very good inflow to the deep femoral vein. Also, the femoral vein is diseased, and we decided to puncture and use the popliteal vein as an access. So we are here now with a bilateral popliteal approach. We have a 10 French access on the left and a 5 French access on the right popliteal vein, and you can here see the phlebography, which Henri will also show. You can see the diseased iliofemoral vein and these collaterals filling the right side and then the vena cava. So the next slide, please. The patient is in a prone position due to the popliteal access, general anesthetic, and we will also show you the May-Turner syndrome with an IVUS, perform pre-dilation, and we decided to use venous obliquous stent for the left May-Turner syndrome.
Yeah, thank you very much. Yeah, so I think that's a relatively typical case with iliac vein thrombosis quite a lot of years ago. Never the diagnosis has been done of a May-Turner syndrome for a long time, until maybe someone who knows the disease meets this patient, and the diagnosis is done, of course. So nowadays we of course also think more of this disease since we have more options to treat it. Let's switch. Yeah, you can see here of hopefully the angiography. So, well, of course, you may not need to do this here in general anesthesia, but this lady here actually wished this to be done in general anesthesia, and therefore you of course do it. Also, if the iliac is not totally occluded, it can be really quite painful here for the patient to balloon this. You can see here now a shot patient lying on the belly, the popliteal vein punctured, that there are maybe some residuals from the thrombosis also here in the femoral vein. You can see a huge insufficient saphena magna vein, which will be treated later on. Then, as you can see here, contrast going down, and then the next is the wire actually went easily in and through because it's not totally occluded. There is a channel through, and you can see here now an phlebography, with collaterals distal at the level of the common femoral artery and going crossover, showing you that the stenosis here of the common iliac vein is hemodynamically relevant. So you can also see that we, from the right popliteal vein on your right side, we went up with a catheter. It may not be completely necessary, but we feel actually much safer if we can really nicely mark our femoral bifurcation when we take the stent in and when we want to be very precise at the Turner point. Well, that's our setting for this patient. Clearly there could be different settings. Here you can see once again it's not totally occluded, but you can see it's relatively narrow. However, also here you may think, well, is it really necessary to do that? And therefore We also have the IVUS here, and if we can switch now to the IVUS.
Andre, this is a great, great case, and it's a fantastic setup. One of the questions I think we all have in the audience is when you're doing these chronic DVT cases, especially iliac vein compression syndrome, what kind of intraprocedural anticoagulation do you use? And what do you send the patients home on after they've been reconstructed?
Yeah, also for us an open question because there's not really a good standard. We do use standard unfractionated heparin during the procedure, aiming for an ACT around 250, something like this. And after that, actually, we switch usually to fenprocommon for some time and aspirin. Usually it's a combination. And thereafter, we either switch to aspirin only or fenprocommon for quite some time. But we do not do fenprocommon for lifelong after stenting, clearly not. It may be rather aspirin, but also here, I mean, we sometimes decide to stop it. I'm not sure how you did or whether you have some standards for this, but it is a case-to-case decision for us.
How long do you keep them on those agents?
Sorry, acoustics are very bad. So it's at least a year we do this anticoagulation.
Can you talk?
Yeah, I think it's always interrupting the acoustics. I cannot hear a word, so maybe I just continue here a little bit with what I have. Maybe it comes back that the acoustic is back, the connection. But I hope you can see here the vena cava here. And this is, you can also see here the catheter on the other side. And now here comes the terminal point. You can see here how narrow this is. And maybe you can show both IVUS and phlebography on the screen in New York. I'm not sure whether you can do this. But you see, this is, the turner point is always between L4 and L5 lumbar bones. So this is also a good marker. And also here, but you can see it's nearly completely collapsed. And when I go further down, you can see that there are some residuals of this thrombosis. I go further down here. You see here now the bifurcation between the external iliac artery and the internal iliac artery. Also here, the vein has some sequela, some membranes here. Although on phlebography it didn't look so bad. However, only here distal to the ligament, it becomes bigger. Here we measured something like 16 millimeters. Now also IVUS should help us here to find the right diameter to treat which kind of stent to take in. So this is here a little bit our reference. So we choose to take a 16 millimeter stent in. But first we have to thoroughly pre-dilate, and of course you could go directly to a 16 millimeter balloon. We are always a little bit, anxious and worried, and therefore we first start here with a 12 millimeter balloon.
Andre, at this point, are you planning on treating, at least pre-dilating the entire iliac segment, the external and common iliac vein, or are you solely going to focus on the area where you've very nicely demonstrated extrinsic compression?
Well, we actually plan to take the stent down to the common femoral vein because here on IVUS it also appeared relatively narrow here, the external vein. So therefore, we're gonna pre-dilate here the whole length. Here you can see once again nicely also with balloon, so the IVUS of the poor man, where the turner point is exactly between the bones here. And how much pressure do you need here? Would you do it differently? Would you just balloon here proximal and leave the rest without a stent?
I think these are issues we're all grappling with about how much to stent. And obviously in Leipzig, you have access to different devices than we have access to here in North America. And I'm hoping you can show us the specific characteristics of the sinus stent because we don't have access to that right now. But some of the issues are whether or not you can treat the lesion with a single stent, whether you're going to need multiple stents. It's obviously clear there's a significant waste there where you've put the balloon. But there are schools of thought that say you should just stent the area where there's extrinsic compression, and there are schools of thought that you should stent from normal to normal.
Yeah. We also actually rather follow the school of stenting from normal to normal. Yeah, correct. We have some other stents than you have. Oh, ein bisschen mehr raus. In the US, we have this sinus oblique stent for the Turner point, which we think is a perfect stent for this, which we want to implant here. It's a relatively stiff stent, actually currently the stiffest one available on the market, and it has an oblique ending here so that you do not hang some stent struts into the common vein on the other side. So really a very, very nice design. However, it's relatively stiff over the whole length. So you can decide to take a 15 centimeter long sinus oblique in, but in this case, for example, without so much residuals here in the external vein, I would maybe decide here to take rather a short, stiff stent at the Turner point, and then go further down with a relatively soft stent. No stent will be long enough here for the whole length, not even 15 centimeter long sinus oblique. So at the end, I do need here two stents. Okay.
Could you
so maybe after?
Could you describe what you would consider to be a venous stent that is a little bit more flexible than the sinus stent that you would think about putting in the external iliac vein here?
What kind of, I'm not sure whether I really got your question. So I think you need a stiff part at the Turner point, clearly. Then there comes another, this so-called second Turner point, where the vein goes usually over the external iliac artery, where you should also have a relatively stiff and a part with a good radial force. And those two points are really solved, I would say, or addressed by the sinus oblique stent. So it's not only stiff proximal, where it's a closed cell part, then there comes a little piece of open cell, and then there comes a second part, which is closed cell in the proximal external vein. And thereafter, I think it depends. It should be more flexible, especially when you come through the ligament into the common femoral vein. Shall we do first an Angiography? Können wir noch mal Apnoe haben, bitte? So this is our phlebography here after ballooning. Clearly there's still these collaterals, and we hope that they will be closed or will not seen anymore. Once we have here stents in and hemodynamically the problem is solved. So I think we can go in now with a bigger balloon. This is a 160 millimeter balloon, and it opens relatively.
Which balloon are you using? Are you using a high pressure balloon, and at what pressures are you inflating it to?
Yeah, it's an Atlas balloon, high pressure balloon. We need more volume in. And we usually go up, usually those veins open up at some pressure like 4, 6, depends on the disease process, but usually it's something like 4, 6 atmospheres. Would you do it differently? Are you afraid of perforation here? Have you?
I guess, Andre, I personally don't routinely place large diameter balloons before I place a stent. In certain instances where it's a complete occlusion, I'll pre-dilate just to facilitate the introduction of the stent. But I usually use large diameter balloons to post-dilate the stent and make sure there's uniform wall apposition. So I think that's a little bit of a unique technique. I'm curious, Anil or Paul or Windsor, whether you guys usually pre-dilate to large atmospheres before you place a stent here.
Yeah, you're right. I guess these are also, let's say, different kinds of schools. We don't do this because we're convinced that the results are, we know that the results are better. We think that
right here. Okay. So usually what I do is I deploy the stent right away. and then deploy the stent, see how the stent expand. If needed, then I dilate the stent, but usually not dilate ahead of time. The only time when dilation is necessary ahead of time is when you have a total occlusion. Then you may have to pre-dilate, develop a tunnel pathway for your stent. The way I usually do it.
Yeah, I agree with Windsor. I usually land the stent and then follow up with post-dilatation. I like the apposition of the stent wall well opposed at the end of the procedure.
In the post-stenotic patients in general, unless it's can't even get the stent up, since we have very limited stents available in the U.S., I usually just put in the stent first.
Druck ist bei Ihnen alles gut, nicht, oder? Okay, now we can take here the sinus oblique stent in. And I show you there are some nice markers which tells you that the oblique part looks into the right direction.
Andre, could you review again which diameter stent you've chosen and what length and
Yeah.
what led you to choose this particular implant?
So this is now a 16 millimeter diameter stent. And because from the IVUS we thought 16 would be the appropriate diameter here, and the length is now 100, so I didn't want to come with a really stiff stent down to the femoral bifurcation, so rather really stop here at the external iliac artery crossing with this stiff stent, and then continue with a more flexible stent.
And this is an open cell stent or a closed cell stent? And we don't
Yeah.
have this in the U.S. So if you could
Exactly.
explain the
Yeah.
unique characteristics of this.
Yeah, you see, so proximal you see a very strong marker, of course, the delivery system. Then you see some small markers. There are 4, and they will look to the vena cava. They will indicate you where the opening of the stent will look like. And then comes a part of the stent which is relatively dense, and this is really the first 4 or 5 centimeters are closed cells, so really strong. Maybe the camera can, you can show it in the camera, the stent here. Hopefully you can see this. Not sure whether, So you can see here these markers, so this is oblique, and then the first part here is closed cell and very strong. And then there are some segments which are open cell and flexible, but the end is again closed cell, and again has very high radial force for the second, so to say, turner point. So that's the design of that stent here.
Again, how do you guys,
Okay.
a quick question for you about oversizing and sizing with the vessel diameter. What percentage do you size up?
Yeah, for us, we do not oversize. So we size the stent according to what we can achieve with the balloon and according to the IVUS measurements. The nice thing also with this stent is you can resheath the stent. If you open up here now the first part, the closed cell part, you can resheath this again if you're not happy with the position and take it to another position. At the delivery system here, you have a little marker. So this here is the point of no return. When you're over it, then you cannot resheath it anymore.
And again, Andre, you're going to use the catheter that's up the right leg to be able to delineate the iliac vein confluence, so you can land the stent exactly at the origin of the common iliac vein. Is that correct?
Yes, correct. Yes. Yeah, we could do now something like a roadmap to have the correct position here, like this here. But again, it's between the bones. And yeah, of course, I mean, the stent will hang a little bit into the vena cava, but I don't want to have it here at the other side of the vena cava. And I give you here some contrast you want to inject for me once I deploy here the stent. So now I start here, just a moment, to first, noch nicht, ne? Of course, it jumps a little bit. First centimeter is a little difficult. You see here now the stent, and I still can rotate it quite nicely now. And look, this is seems to me to be a good position. However, maybe I want to go a little higher with the stent. So therefore, I could resheath it now, as you can see here now, a little bit, push it a little bit higher, and then once again. And I think this could here be, bitte, a very good position here.
That looks
of the
perfect.
stent. And now, yeah, I think this is very good. I mean, you should clearly also hit the turner point and not miss it by being too strict here to one side. And now clearly there's no return anymore. Just a moment. Yeah, now it's fully open, and we need to take the other stent in. Yeah, I'm not sure what your time schedule says. I could give you now a phlebography.
I think that would be great if you could
Or-
show us where you landed it
Yeah.
with respect to the iliac vein confluence, and then
Yeah,
go
yeah.
over how you're going to choose the next stent to implant.
Yes. Könnten wir auf beiden Seiten nochmal injizieren? Erst ich, dann du. Das ist ein bisschen zu wenig. Könnten wir nochmal Apnoe haben? Also, oder wer injiziert hier? Erst ich. Jetzt Sie. Ja.
Yeah.
I think it's quite nice. I mean, can be some millimeters further into the right side, but altogether I think there is good flow here from the left side, not going to the other side of the cava. So I'm actually quite happy with this position here.
No, I think it looks ideal. I think one of the questions that we're all thinking is, are you planning on post-dilating the stent? And if the answer is no, do you make that decision just based on the venogram, or are you going to follow it up with intravascular ultrasound to determine whether or not the stent needs to be opened up a little more?
No, actually I want to post-dilate it. I will want to bring it to its maximal diameter, and ballooning showed already we can gain more here. For choosing also here the right length of the next stent, I'm gonna take in once again the IVUS catheter with the calibration markers on it, and this may be my overlap, and we can here with another venogram decide which length to use. Yeah. So what do you think? Would you go over the Safena, or would you? Actually, I would not go over the Safena, but rather just take the stenosis, the residual stenosis there, and keep it at the femoral head.
I would go all the way down to where the confluence is of the saphenous and the femoral vein, right on top of those collaterals. That's just my
top of those
opinion.
collaterals,
I think you're looking at it probably another 10
Yeah.
centimeter stent.
Yeah, or 12.
Yeah.
12, huh?
Yeah, we do
Yeah,
have
16,
12.
12.
And are you going to choose
Yeah,
the same diameter, a
16
16 millimeter diameter, or are you going to choose a different diameter at this point?
No, actually it's going to be 16, because we measured also 16 in the common femoral vein, so I think this is the right diameter, and also the balloon opened up to 16. Yeah, it will only be completely different with design. It will be open cell. You will see it looks very flexible. These are, so to say, stent segments which are connected to each other only by 2 bridges always. So that makes the stent relatively flexible, and therefore maybe a good design here for the ligament area.
I'm sorry, you might have mentioned this. Which brand device are you planning on placing here into the external iliac vein?
Yeah, this is now the Venous from also for the same company. It's a German company, Venous Stent. So completely different design, actually. Okay, Drahthaltung.
Can you tell us what's the length of the stent you're going to place in the external iliac vein?
It's 12 centimeters. Could have been a little shorter. What do you think? I would stop here, actually. Something like here.
Yeah, we need to go
Did we
back
do
to your
this,
to your
or-
fluoro image. We're looking at the stent
can
now,
we
which
go
looks like
back
a
to
very
fluoro?
nice
Oh, yeah.
open cell stent.
Yeah.
So I would
So
I would
that's
want to
the-
be like I think 5 millimeters higher than that, just so that you don't completely cover
yeah.
that critical
Exactly.
collateral there.
What's the width
Exactly.
of the stent that you're going to be placing?
I
Sorry?
think he said 16 millimeters, the same as the common iliac. vein
16
stent.
millimeters.
16, yes.
Yes.
I will also add that this IVUS is very useful here to look at your vein distally to see exactly the place to put your stent.
Yeah. So I'll take it here now. And shall I change just a moment? We need to take this eye,
Warte mal. Geh und
the roadmap off so that you can here now see how the stent opens. You see here, by every pull, a segment, a ring opens up. So clearly you're not allowed to pull on that stent because then it gets elongated. And only by this slow implantation it remains in that morphology and form which you want to have. But that I think looks already quite nice.
I agree. That looks like you placed it perfectly.
Yeah, we can give you now already a venogram, and then depends on your time. You can wait for post-dilation, or we can show the result later here.
Michael?
I think we have time to see the venogram, and I think we're going to move on then,
Yeah.
Andre.
Okay, noch einmal Apnoe bitte. I think this looks already very nice. Collaterals are gone, so the flow obstruction is gone.
That's a beautiful result.
Yeah.
And you didn't cover the collaterals over the femoral head, so
Yeah.
it really couldn't look any
Yeah.
better.
Yeah.
Thank you
Okay.
very much. That was a fantastic case
Fine, yeah.
showing very
Thank you
interesting
also.
technology. Great
Thank you.
job.
Thank you.